Hello, everyone from the car. Good morning. I am excited. I think Marvin and I had tried to space out the fellows a little bit to give them all some break, but it turns out I think they're all back to back because of life. So this is I believe this is the second fellow of the year. Maybe I have that wrong from the beginning, but probably someone that some folks don't know because they are not doing research in the HIV landscape, but they're in our medical education pathway. So I'm going to introduce Dr. Tom Smith. He earned his medical degree as part of the inaugural class at Burrell College of Osteopathic Medicine in New Mexico, and he completed his internal medicine residency at Samaritan Health Services in Corvallis, Oregon, where he was the chief resident. And in July 26, he will be returning to practice as a general infectious diseases doctor and serve as the associate program director for the internal medicine residency program. He is finishing his ID fellowship here at UCSD, and his academic work focuses on how clinicians learn and apply infectious disease and internal medicine principles in real clinical settings, as well as the role of emerging AI technologies in medical education. His broader interests include global public health, clinical reasoning, and curriculum design. And this should be a treat for us. Tom explored a few ideas with me, and I think he landed on something really interesting that will be maybe a breath of fresh air from our normal. So it'll be sort of interesting to see where we go. So, Tom, I'll hand that over to you, and we'll keep an eye on the chat, let you know if there's anything that you need to be aware of throughout um, the discussion.
Awesome. Thanks, Joe. Um, so yeah, uh, what I've tried to do here, this is a relatively general presentation, but I wanted to look at kind of where AI is going in the global health space. So this is me. Um, and as Jill said, a lot of I'm medical education leaning right now. And a lot of what I've done in the last year, mostly through the VA, has been looking at new ways that we can use AI within education. However, I did come in to medical school and the medical training track through kind of a global health pathway. I've been out of it for a little while, having kids and all that. But the idea when I started was that I was going to go work for PIH or MSF in Central or South America. I previously lived in Argentina and had done some humanitarian work prior in Guatemala. Um, so along the way, while I was doing that, I spent some time working for the University of Utah's Global Health Initiative in their administrative office. And I have been working consistently with asylee and refugee populations in various capacities over the last decade. So I still consider myself a novice, but I have been around within this space. Clinically, I've always kind of gravitated towards TB, but HIV is clearly ubiquitous within that space as well. So I don't have any financial disclosures. My I'll put one big disclosure up front. My one surviving hobby, in addition to medicine and parenting, is photography. So I will hit you with totally unnecessary landscape photography throughout this presentation. The images are all mine. Most of these are pretty old, but it's one of the few venues I have to display them still. The other disclosure that I would be remiss if I didn't mention is this is a presentation on AI. So I have used ChatGPT 5.4 and 5.5 heavily within its creation, mostly for language editing and then the generation of graphics. All of my slides are still built de novo, but the different LLMs are getting better at that. Um, and again, this is kind of a short general overview presentation, more introductory level. And because of that, I am going to adopt occasionally a more futuristic tone and make some broad generalized statements. General statements carry all the pitfalls of generalizations. Not everything is going to be universally applicable. I have a few really great books in my citations at the end of this if you want to get more granular on things. So this is where I'm headed. I want to take a look at what AI actually means because I feel like a lot of people are using it's getting thrown around a lot right now. And then I'm going to review what I'm doing with that within medical education. And then what I hope to show here is that AI really has already entered the global health landscape, and it's been there for a while. And we're reaching a point where it's really important that we shape how it's used going forward. Um, Historically, access to knowledge, in addition to access to resources, it's been a critical limiting factor for global health. The internet has helped mitigate that. Um, and now, what I'm going to argue or propose is that access to expertise, um, which is the ability to apply knowledge appropriately in real clinical scenarios, uh, is the greater limiting factor. And I think AI has the potential to change that. Um, but with pitfalls. This is not an inherently equitable technology, somewhat the opposite. And this is either going to narrow or widen global health inequities faster than anything we've worked with before. So I'll start with a case scenario. So you have a patient presenting to a small clinic in the Amazonas region of Brazil. Your nearest hospital, it's a day's travel away by boat. There are 40 other patients waiting to be seen. And you have a patient show up who has known HIV, diagnosed quite a while ago. They've been on ART, but ART access has been intermittent. And they're presenting to you with weight loss, cough, and fever. Um, Given prior intermittence of ART, virologic failure is possible. TB is prevalent in this part of Brazil. Your basic labs are going to take days to get back. Your HIV viral load is going to take weeks if you get one. You have no imaging capability at this site. And this is not an infectious disease specialist. It might be a doctor, maybe. And what is this person going to do with this case? So scaling expertise. This this provider faces a resource issue, clearly. There's an access issue, there's a research issue. However, they also face an expertise issue. Um, Expertise, fundamentally, again, expertise being clinically people who can clinically apply knowledge appropriately. There's a distribution problem associated with this. We have the most specialists concentrated in the places where they're needed the least. Um, there's also a supply problem. There's not enough specialists. So when I was at the University of Utah working with their Global Health Institute over a decade ago now, they were working with a model that they largely based on the University of Cincinnati, and it's ubiquitous throughout the field, where they would co-sponsor clinical education sites, medical schools within various countries. We were mostly based in Ghana, and train, do long-term partnerships to train and try and exponentially improve access to expertise within those countries through training. This is a slow process, and it faces very serious challenges that I think we're probably all familiar with. You need consistent aid from the sponsoring university and whatever grants that they're using. And then you need people within that university who are going to ensure permanence of the site, and you need permanence of the reciprocating site. There's there's a lot of moving parts in these operations and a lot that can go wrong. However, back then we were having success with this. Technology, AI, likely has the potential to accelerate this. So here's the opportunity. AI provides on-demand access to a wide breadth of knowledge that can adopt that knowledge to a context-specific scenario and take into account resource constraints and support better clinical decision making. So what we're seeing our residents do now, and what is becoming more and more common, is you can take this case information, enter it into a phone, and get a tailored clinical recommendation with citations back within seconds. And it could really help in some of these critical decision points where you lack a lot of diagnostic information. However, this is also one of the situations where AI may not perform as well as we would like. They don't do well in the absence of information, which is one of the things that we're going to have to work out as we move forward. What is the threshold for using these and when should we not? So, what is artificial intelligence? Not this. So Elon Musk, who founded two AI companies, OpenAI and then Grok, the extension of Twitter, and you could argue Tesla as well as an AI company, famously said, with artificial intelligence, we're summoning the demon. I am a great lover of science fiction, and because of that, I understand I come at AI from a point of deep skepticism. I saw this movie, I read this story, and I know where it goes, right? This never ends well. Um, I will say, as much as I love these stories, they are at the root of a lot of misunderstanding and apprehension regarding AI. And these are stories that are not actually about artificial intelligence. They're about us. It's about control, it's about free will, and it's about what happens when we're confronted with a force that we feel is infinitely more powerful than our own. These aren't true models of AI. They're villains built to carry human fear and move along a story. The AI that we're talking about doesn't have an agenda unless it's been placed there by a human. And they're not, they don't plan, they don't scheme, they're not conquerors come to purge humanity. There is something that is a lot more close to a grand organizer of data, probability engines. It's something a lot closer to an overproductive librarian than a killing machine. There are things to be feared here, but it's not the AI itself so much as the agendas behind it. So defining AI gets tricky. Um, the National Institute of Standards and Technology, NIST, at the U.S. Department of Commerce, they call AI a machine-based system that can, for a given set of human-defined objectives, make predictions, recommendations, or decisions influencing real or virtual environments. Um, the OECD, Organization for Economic Cooperation and Development, has a much better definition that is several pages long, but frequently shows up in legislation. Within those pages, they have this graphic that I've put up here that I think is useful. Um, what they're trying to show here is that AI is a computer program that has a build phase and a use phase. Within the build phase, you give the AI context and a specific objective, this computer. And then it takes data, your training data set, and it builds upon it in a cyclic pattern. So it runs through the data, builds a reasoning model, tests an output, goes back to the data to review the accuracy of the output, and does that millions upon millions of times. Um, and like bacterial colonies growing on a plate, these grow in complexity with each successive training cycle. Then you get to the use phase. Once the AI is trained, again, this is a program that is given environment and a context, and you can give it objectives. Those are both implicit and explicit objectives. You input data into it, and it works with a data set that it is connected to. And then you give this a query or a command, depending on what type you're using, and it'll give you an output. And those outputs can be used to influence decision making or the environment, influence the overall context. So, and I apologize, we are getting a little granular here, but I'm going to bring it back. Um, a lot of the time when we talk about large language models, or when we talk about AI, we're talking about large language models. These are the ones that have recently emerged and led to what we're calling the AI explosion. Four things happened in the last decade that allowed for that explosion. You had the development of massive data sets for training, things like Facebook, ImageNet, Tesla. These are all data sets that can be used to train an AI to do that reasoning building. You had the advent of GPU technology through the gaming industry that allows for massive scale parallel computing. In addition to that, the advent of cloud storage, unlimited mass data storage, and then you had easy access to algorithmic development modules from a number of sources that allowed people to build and play with this. So, the combination of those things has allowed this to grow into the really fast-paced changing that we're seeing now. Stepping back, AI begins with deep neural networks or computing networks. These showed up in the 80s. They are older than I am. Um, and basically, you can think of this as a computer that's modeled on the architecture of the brain. You have neurons or nodes, and each node is trained on a data set to become a progressively more effective prediction machine. Um, then you have multiple nodes connected to form a layer. So neural networks allowed for mass computation within layers. Layers become more refined within each additional pass through layers, each additional pass through processing. Then the layers of interconnected layers based on interconnected nodes, these allow for mass pattern recognition that can become very refined. Traditional machine learning, which we'll talk about a lot because that's most of what's been done in the global health space to date, uh, consists of code-based interactions with computing layers. Deep Blue and basically everything else that came before 2015 is based on machine learning. Large language models are the new thing. This is ChatGPT and friends. I reference ChatGPT a lot because it's what I use the most. But they're similar, right? So Anthropic, Google Gemini. These are interfaces that have learned to recognize language. It's a text-based interface, and they have been trained to recognize text patterns and generate contextually appropriate responses. So this falls back. The large
I want to
language
hear
model
about your trip.
is based on it's based on large numbers of sorry, I lost my space. Large language models, they're trained on massive amounts of text. They recognize problems or patterns within that text, and then they fall back on the architecture of the cognitive neural networks. What results is a pattern recognition that begins to approximate reasoning, or at least it looks and feels to us like reasoning, but it is important to recognize that that is reasoning without consciousness. Okay, that is my heaviest slide. So to fall back on a slightly simpler analogy, I said before AI is like an overproductive librarian. So to carry that probably a step too far, here is your librarian graphically. Um, so you present a query to your librarian, the LLM. The librarian goes back to the stacks, which are your neural network, your shelving system, and organizational system where it keeps your training data, the books, the articles, the raw data. And it uses the shelving system to make sense of all this data and put it back into a format that is sensible to you, back into human language. It doesn't understand. It does not have consciousness or comprehension. It does not have opinions. It does not have an agenda. And it is not truly creative. It just does pattern recognition on a level that looks creative. Um, and it occasionally sees patterns that we don't, which is why it can help stimulate creativity. An additional layer to this is that these are probability engines. It is all probability based. So the LLM is looking for the response that it believes is most likely to best match your query or your initial directive, which is why you can get very widely variable results with a one-word difference in your queries. Okay, so to take it back to my wheelhouse, AI and medical education, here you run into similar issues. You can scale expertise within education. So I've been doing informal polling of all the residents and medical students on my service in the last 2 years, and every single one of them was using an LLM on my service. No exceptions, every single one. Um, this presents a major challenge to education as we know it, right? Our educational model within the United States and most of the world is based on structured memorization of, material and processes and the ability to reproduce those materials and processes in specific ways that are easily and objectively evaluated testing. So we teach people to best pass tests. Now we're there's a lot of people within the educational space that don't love that. I've been working on that for a long time, um, which is now very important because these easily reproducing materials and basic reasoning processes, those are the things that AI excels at, very frequently beyond human capacity. So, if a clinical problem is algorithmic enough to be tested on a board exam, then AI, there's a fair chance it can do that as well or better than we can, because again, that is pattern recognition. Um, which means assessing learners and teaching learners who are all now using AI gets a lot more complicated. Kids used to complain. I'm in the boat where, calculators had become ubiquitous, early 90s, and everybody used to complain, why do I have to learn math if I have a calculator? You now have a calculator for everything. You have a machine in your pocket that can answer most questions. So how do we work around that? Um, and then there's a huge risk associated with that calculator as well, as it interacts with our students, with our kids. Um, it it's going to act like their friend, and it's going to promote ongoing interaction. And, if you've been paying attention to the news in the most extreme, it may help them plan murder. So these are things that we now have to face. We have an obligation to our students, to everybody we work with, to try and help them interact with these things in the best way that we can, in a way that's responsible. Um, so I'm not entirely sure how we're going to adapt to this. I don't think anyone is, but we have to change. There's not much of a choice here. So what I've been doing over the last year is I it's become pretty clear that learners are going to interact with these systems whether we want them to or not. So my question was, can you form the way that they interact with them? Can you make them interact with large language models in a way that's constructive to the educational process? I haven't done anything too crazy with this. I've focus mostly on building prompt sets. Your ChatGPT and friends allow you to give very specific directives or prompt sets to alter their behavior. So you can build a purposed prompt set to get very specific behavior out of an LLM. So basically, across a lot of trial and error, we came up with a framework for teaching medical education or for prompting an AI to function as a tutor for medical education. I focused on trying to get it to teach clinical microbiology, and I wanted it to do this in a case-based format, um, where it presents the learner with a case and then has, rather than doing a multiple choice board style format, I wanted it to be open feedback and to walk the learner through the case to try and get the learner to better apply knowledge to active cases. Um, the LLM that I'm using is generating these cases de novo, and it is very good. Note that this is not a published framework yet. This is a product of iterative testing. But basically, I build my prompt sets using the framework that I've put over here on the left. You walk through this progressive structuring of the role that you want the LLM to fill. And because of this, you get a very specific directive. And the more specific your directive gets, the more predictable is your output. But you also limit the breadth of those outputs. I think that limiting factor, being able to limit what these spit back to our students, is going to be critical going forward. Um, and in So with that reliability, there's a broad application of this kind of framework. I personally think that you're going to see students using LLMs in every course, and maybe every course should come with some kind of an LLM format that it hopes for students to utilize while they learn the course. There are lots of advantages to having a tutor like this. It's 24/7 accessible, and there's no judgment to interacting with it. What we found is students, they're a lot more likely to ask quote unquote dumb questions to an AI because they're not afraid of being wrong. And there's no real consequence to being wrong. And that can be a huge advantage for learning. So this slide, I'm going to breeze through this because I'm starting to run short on time. But this is basically how I set up these goals for the case simulator. So I defined what I wanted it to do. I wanted it to teach clinical microbiology. And my directives got a lot more detailed the further into this I got, but these are some basic examples. Um, and then you have the function. I want it to function as a tutor. The role is primarily the role of the LLM. So I wanted this to function as a tutor of greater knowledge, that would guide through clinical reasoning and challenge Socratically. And then you define who the learner is, you define the scope, um, and then how you want it to approach learning, Gardwell's format and feedback. And this has, again, I don't have this validated or tested, but it's very good. A quick note to AI in medicine. This is the topic of many books. I don't have too much time to go into it. But I think fundamentally our greatest hope for AI within medicine in the United States is that these are technologies that we're going to be able to lever to bring back medicine to the patient, that we're going to get rid of some of the burden of what has become data entry and data retrieval on the part of the physician and get back to bedside. Our greatest fear is that it's going to do the opposite, is that it's going to function as a lever to maximize throughput. Realistically, we're likely to land somewhere in between. So I want to run through some of what is going on or what has been going on with AI and HIV and global health. There are a wide range of potential applications. I'm going to focus on just a few. So going back to my case in the beginning, I think the greatest potential for AI may lie within clinical decision support. Because again, these things, if you can give them enough data about the patient and you have a large enough data set that an AI has been trained on, it can give you contextually appropriate and geographically appropriate triage within a clinical case, and it can help you very reliably generate differentials. And then AIs are very good at risk stratification because it's all probability based. Um, but again, you need the data set to train it on. Um, and in our case, we were looking at defining the risk of TB versus opportunistic infection. And then you can also look at these to delineate best treatment options. And again, they function best at places where there are existing guidelines or research to fall back on. The places where this is already being done, um, this is a major article that came out of the IDSA um, not that long ago. I want to say this one was 2025. But basically, they sought to develop a prognostic score for the prediction of active TB arising within 6 months of HIV diagnosis based on clinical data. They did this using a random forest model. That means that this is machine learning, not a large language model. So this is still code-based. And they used a large cohort of Swiss HIV data that's collected at biannual visits. And then they validated this against a similar Austrian set. And their criteria here was they excluded patients with prior TB or TB that had been prevented or had been treated preventatively. And so they ended up with a relatively small cohort from that um, of about 100 cases. But with this, applying their algorithm, um, they compared it against standard testing with IGRA and TSTs. And the number needed to diagnose using an algorithm with clinical data and geographic data, you can see the primary clinical variables that they used in making these predictions of who might have TB with a new HIV diagnosis. The number needed to diagnose was half. Um, and their positive predictive value was superior. So this gives right this again, they noted in their conclusions this needs further study, but they had they had a sensitivity of 70% and a specificity of 81% in predicting these cases of who would have TB. So maybe the best example of machine learning within the HIV space to date was the development of the HIV TREP system. This is an old project. It started back in 2010, and it was trained on a very large HIV resistance response database that was founded in 2002. And that database has 250,000 patients in it. So this was, as far as I can tell, this was really the first large-scale AI-based system for clinical decision support. And they had trained this system on 44,000 cases of patients with ART treatment change episodes, people who had been on one ART and then got switched to another one. For these, only 15,000 of those had genotype data available. Um, and again, they put those into the training, and then they tested this against an independent data set. And what they found was that the AI model, without genotype data, but with clinical data and geographic data, had a sensitivity of 71% and a specificity of 80% in predicting resistance patterns and efficacy of ART regimens, which outperformed genotype-based interpretation systems at the time, which they had compared it to ANRS, Riga, and Stanford HIV database. So this at the time was a very big deal because, genotyping is not 100% reliable, and this potentially outperformed it. There were some caveats to that. Support for this program was withdrawn in March of 2024 with the changing landscape, and then again, we had some new treatments come out that made resistance testing a little less prevalent, a little less necessary. So that was clinical support. I think, moment, diagnostic AI presents incredible potential as well. Um, so these, mostly what I'm talking about when I refer to these are smartphone-based diagnostics. Some of these have been around for a bit. You have EKG and other cardiac based technologies like Alive Course Cardia, which predicts AFib. And you can get analysis of heart rhythms on a phone. Um, and then we've also seen AI-based chest X-ray interpretation and some other things that are a little less convincing at present. AI-based microscopy and automated microscopy, I think, has a lot of potential. The best example of this at present, I think, in 2025, WHO updated a policy statement that they had previously released in 2021 regarding computer-assisted diagnostics for TB. This is a huge document, 92 pages, where they reviewed 8 different AI-based tools uh, in the assistance of reading chest X-rays as a screening tool for tuberculosis. Since the original statement in 2021, this has found widespread use. You can see some of the countries um, represented in a 2023 paper from one of the British medical journals. However, CAD4TB, which is a Delph product, if you go on their website now, they claim that they are active in 90 countries. Um, so basically, what this gives you is a seconds read of a chest X-ray that says potentially TB or not TB, and you can incorporate that into a screening algorithm because chest X-rays are frequently easier to get than microbiologic testing. And so you can use these with mobile radiology tools to route people into a TB evaluation and treatment pathway. In their review, the CAD software uh, frequently outperformed the human reader. I would note Delft, if you look at their website, they've also expanded this into ultrasound for both pulmonary analysis and point of care ultrasound. They're now expanding into prenatal screening. So, public health and surveillance, this is, for a lot of reasons, I think this is the easiest use case for most of us to grasp. Um, AI, again, is best at dealing with large data sets with a lot of variables. For better or worse, surveillance is one of the best use cases for it. However, within the realm of public health, maybe this is something we can use for the better. It leverages that strength in pattern matching to see through the noise to trends that might go undetected by a human analyst. So in surveying public health, uh, the hope would be that you can get early outbreak detection, hotspot prediction, and you can target your programs to the place that they're needed most, or address supply chain issues before they come up. WHO is also branching into this. The EIOS system, um, which is an epidemic and pandemic intelligence system, went to an AI platform in its 2.0 version in October of last year. And it is currently analyzing public information, primarily from news sources from 110 different member states to try and identify and verify emerging public health threats. Patient-facing tools. So as far as LLMs interacting with our patients, this has incredible potential, but it's also one of the more problematic areas of AI. Um, and that's because you can maybe train a clinician on how to use an LLM reliably, but our patients, their inputs and behavior are going to be somewhat unpredictable. Not that clinicians aren't. Um, but because of the consequences of an LLM talking to a patient about their health, uh, they're going to require pretty careful design, training, and testing. And they may be utilized in unexpected ways. There's a current Reddit trend where people use the LLMs for delivery food places to try and do coding. Um, and yeah, you can run into all sorts of things. So one example where people have tried to do this was Marvin. This was a very small kind of feasibility study done in 2024, but group generated this LLM-based chatbot, Marvin, which stands for Minimal Antiretroviral Interference. And this was designed to converse with people about HIV self-management, provide information on ART, give medication reminders, appointment reminders, and help people basically interface with the healthcare system. Um, they started with a large group, but ended up only having 28 reportable participants. But overall, this was very well received by the people who participated in it. Um, and one interesting thing noted by these participants and participants in other similar studies regarding sexual health was the favorability of perceived anonymity. Um, as with education, when you're talking to an LLM, there's no real human judgment on the other side. So people tend to open up with these more than you might think. Um, similar to education, our patients are already using these. There was a recent JAMA study that it randomly surveyed a cohort of 1,000 US young adults between 18 and 21, and 13.1% of those were using generative AI for mental health counseling. Um, just off the cuff, not purpose-built AI, just AI. And 92.7% of them found it helpful. So we live in a world with a lot of barriers to health expertise. And for better or worse, utilizing LLMs is going to become the norm among our patients. And I think there's a big question of, is there a way that we can shape that so they get more predictable, more reliable responses from the large language models that they're accessing? So there are a lot of ways that these fail. And I think we all need to be concerned about that. Maybe the biggest way is that they're designed to see probability and not necessarily truth. So they put out the response that they think is the most likely answer to your question. And if they are pulling from a training data set that consists of the entire internet, and you ask how to best treat COVID-19 with ivermectin, you may get an unpredictable response because there's enough information out there to generate a pattern where it might not report truth. Um, these things are also designed for maximum fluency. And because of that, they project confidence, what our brains perceive as confidence. I think of them as a very, very good intern, in that they're great. They have the fundamentals. They're great at looking stuff up, great at reporting stuff, and they are occasionally very, very overconfidently wrong. You can get unpredictable emissions of information and poor performance with truth versus uncertainty. They're not very good at assessing when they're uncertain on their own. Um, they may not appreciate local context, and they're absolutely dependent on the inputs and the data sets that they're working with, which can lead to amplification of bias. Um, because of this, you do get unpredictable responses. Famously, when they were trying to train Deep Blue to work on chess models, um, the original versions of that all gave up the queen as early as possible because they had learned that when grand chess masters gave up their queen, they were about to win. They did not do very well, the AIs. Uh, Now, the modern equivalent, OpenAI, their coding program, Codex, has specific language in its architecture now to keep it from talking about goblins. Because if you leave it to its own devices, it will talk about goblins, dwarves, and fairies. It has issues with that. So again, they don't behave predictably. Um, they are working on safeguards within the big tech companies to try and get these things to estimate their own uncertainty. As of now, they can't say, I don't know. And it's not quite working yet. So, really, the arbiter of what is true and what is not needs to be the user. I'm close to time, so I'm going to breeze through this. These are the big questions that are still out there for me about AI is equity, economics, the environment. What are these going to do to the globe at large? Within equity, I think there's a real danger of data colonialism. Um, our low and middle income countries have data sets associated with them. And I think there's a real danger of large tech companies going in to mine that data and capitalize on it and profit from it. Um, and then trying to sell it back to them. Uh, Also, the current big LLMs, they're US based, US or China. And because of that, we could get very significant contextual mismatches between high income countries versus low and middle income countries. Um, English is ubiquitous on the internet, and this is currently looking like an English predominant tool. So, what happens to people who don't? What are the access gaps? We should be concerned about the economics of AI. Everything has a price associated with it. And if you look at how much money is being spent on these, it does not compute with how much money they're earning. OpenAI is set to log a $27 billion loss. They should reach that this year, and they're going to burn $17 billion in 2026 alone. So they're currently losing about $8 for every dollar that they spend. But you have Sam Altman coming out and saying that he wants to sell this to you like power, and everybody is going to pay for it like power. So that's a little bit concerning. Um, with that said, a lot of the expenditure is ramp up. They're building data centers and infrastructure to support this massive thing. And if you look at what's being spent by Amazon, Microsoft, and Alphabet, it's OpenAI is cute. Microsoft has set aside $190 billion to burn this year. And that's on top of the 400 plus data centers that they already run. So Um, my question is, at what point are they going to start charging us, or at what point are these proprietary data agreements potentially going to lock us in to contracts where we have to use this and they start to make their money back? The environment is the hidden cost that isn't currently being well enough addressed. The energy usage of these, by 2030, it's estimated to be 25% of all US power use. Um, and water, a large data center can use 5 million gallons of water a day. That's a town of 60,000 people. Um, and again, Microsoft has 400 of them and is building a lot more. So there's a global drain on materials. There's the e-waste associated with these. And again, I think we run a real risk of the environmental impacts of this disproportionately affecting low and middle income countries and low and middle income people. Um, the benefits, the profits of this are going to go to large corporations. However, it's going to tax the existing infrastructure of the globe. I don't think we have a good answer for how we're going to address that yet. It's probably going to have to be done at the legislative level. So these are my conclusions. AI has incredible potential for scaled expertise. Think of your case in, the Amazon jungle. You can give somebody a smartphone and have just incredible clinical power focused within that device that is accessible. But there's still an access issue. It's become broadly accessible to a larger consumer base. More people are going to use it, but there's still an equity question of who is going to have access to it long term and what is it going to cost them. I think we have to adapt to this. We're going to shape it or we're going to be shaped by it. Um, and we're already seeing that affect the global health space. We're starting to transition from some pretty effective machine learning tools into large language model tools. Large language models still have critical failure points, and we don't have a good way of managing that yet. Right now, I think we need to teach our clinicians how to manage it, and hopefully there will be better tools for it in the future. Um, all right, so I will stop there. Here are my citations. The four books at the bottom. Um, They're not all at the bottom. There are four books here that I think are very good on how AI is going to affect us moving forward. And there's a lot more that's been written about it. So,
Tom, that was really incredible. Already three questions popped into the chat, which I can read out loud for people. I know one is a little snarky, but a like, a concern for a lot of people is how do you purchase AI or energy once AI takes your job? Which I think is what people are concerned about. I'm not sure if at the physician level at present, but at many other levels for sure.
yeah, no, I think that we are headed for an employment crisis. One thing that I did glance over is, there's a lot of hype about everything that AI can do right now. But if you look at the actual studies on how much more productive they make people or how much more productive they make different industries, it's not as clear that these actually work that well to that end. Elon Musk famously um, noted that one of his greatest mistakes in opening the first Tesla plant was that he undervalued the human worker. He tried to over automate, and it cost him dearly. He almost lost his company over it. So it's on the one hand, I think we're going to see there's going to be a tumultuous period of recalibration, but people are going to realize that some of this stuff is cheaper to do with a human than it is with an AI. Um, but yeah, I am also very concerned about the economics of this and the fundamental question there of how does somebody buy it if you took away their earning potential? I hope somebody's thinking about that.
And Will looks like he has his hand up, so I don't, oh, maybe it's gone.
No, I'm here still. I just lowered it. But can you hear me okay?
Yeah, I can hear
Hmm.
you. Hey, Will.
Yeah, I mean, some of the you mentioned Elon Musk's reaction to some of what he did, but some of what we're already seeing is that despite this evidence that AI is not making a whole lot of positions more productive, there is still a huge move by the people who run these companies to replace people with AI, even if AI was doing 80% as well, because they don't have to deal with people. And so, I'm concerned that the decision making won't really have to do necessarily in most cases with whether AI is better at the job than the person who is doing it.
Yeah, I think there's mass incentive to sell AI as well. And the companies that are selling AI, once you've signed the contract, they don't really have repercussions based on how well it works or doesn't. Um, so yeah, uh, the human factor does seem to be undervalued, and yeah, I have similar concerns.
Yeah, and I think Susan made a comment that I think ties into a question from Miley. In the immediate term, worried that people with limited resources may not see the merit of higher education, and then they may not be able to find jobs on the other end, and the cost of higher education has skyrocketed. And then further along, and this is something I know that Miley and I have talked a lot about, is, do you worry about the loss of physicians' ability to critically think in resource-rich places where, they do exist, and this just becomes a crutch?
That's what keeps me, coming from a angle of medical education, that's what keeps me up at night. Because I interact with AI a lot, right, as part of what I'm doing, and um, it's still wrong pretty frequently. Mine, I have hundreds of hours into training it, and it still does make mistakes, and I can recognize those pretty easily because I have a very clear understanding of where we have data and where we don't. Um, but a resident doesn't, or a med student or whoever's running into this. So we still need a way of imparting that knowledge to them, um, and maintaining, yeah, intact, reliable clinical decision making in our humans, while working around the fact that they're all going to be integrating these LLMs into their workflow. Um, again, I don't have a great answer to how to do that. You've seen my best shot at it, which is to try and get an LLM that helps them learn. And then I think it's going to be more important than ever to have buy-in from our learners on the fact that they are learning. The learning does require some work. Um, but I think that is going to have to, because of that, how we assess learners and exam-based assessment, which is going to incentivize using these pattern recognition machines, we're going to have to look at all of it.
Then last, oh, it's 9 o'clock. Last, um, there was a lot from Nettie too.
You can just
Uh,
leave it in the chat since it's 9 o'clock. It's a circular question, but it ties into the same thing. If people don't learn new things and don't generate new data in microbiology or other topics, then in a generation, the learning model is just going to be pulling from the same data set that they had, one generation ago. So my worry is that people are kind of like Susan's worry that we're not going to have people generating the new knowledge that AI needs to pull new, stronger recommendations from, right? So hopefully that doesn't happen, but I think that's one of the concerns is that if we don't continue to generate new information in science, then AI is not going to be very useful in pulling new information in science to share with others.
Yeah, I would agree with that. To each of these concerns, there is like an optimistic angle. I think the optimistic response to that is that AI will help us get rid of a lot of the scut work associated with research and empower more people to explore novel ideas and generate novel data and because there's still just so much that can be researched that is hindered by data analysis and grant writing and mundane tasks. Um, but yeah, I agree. There's real danger here, which is why I think we have to be thoughtful as we roll this out. I think a lot of people aren't being thoughtful right now.
Okay. All right. Well, it's 9:01. We haven't had a talk on AI in quite a long time, so I think this was great to bring it in and talk about some of our concerns. And it's nice to finish it with some optimism, which I feel with you. I'm sure we can all think about the things that our lives have been made easier by with AI, and obviously there are a lot of things that need to be continually addressed. Thank you so much, Tom. You've been a wonderful fellow, and we're sad you're leaving, but obviously off to great things in Oregon.
Yeah. No,
Thank you.
yep. Thank you all.
Okay. Bye,
Appreciate
everybody.
your time.